Right. So good afternoon, everyone. Thank you very much for joining us for our health seminar today, which is organised by the Centre for Primary Health and Social Care at the School of Social Sciences and Professions. My name is Yolanda Eraso. For those that don't know me, I'm from outside our university. I'm Professor of Health Studies and Director of the Centre. So I'm very pleased to introduce our speaker today, Dr. Teresa Corbett. She's Senior Lecturer within the Department of Social Sciences and Nursing at Solent University at Southampton. Teresa is a chartered psychologist with the British Psychological Society and is a member of the Division of Health Psychology within that association or organisation. Her research today has focused on psychosocial oncology, health behaviour change, and the development of acceptable and engaging interventions for those self-managing chronic health conditions. In particular, her research explored the barriers and facilitators to implementing person-centered care approaches in practice. So her seminar today will draw on some recent work she conducted on the provision of personalized care for older adults living with multiple complex conditions and people who have diagnosis of cancer. I believe this research was also funded by the National Institute of Health Research, but I'm sure Teresa will give the full details on the grant on that project. So we will have time for questions and answer at the end of the presentation, and I always ask the audience to use the chat box as we go along, so we can come back then to those questions at the time of our discussion. And also to let you know that we're recording the session and that the video recording will be uploaded to our Centre for Primary Health and Social Care webpage. So that's all I'm going to say today. I hope you enjoyed the seminar. So over to you, Teresa.
Thank you very much, Yolanda. So thank you for joining this afternoon, everyone. I'm going to talk today about two separate studies that we conducted. So there was a thematic synthesis and a qualitative study, and these were both focused on effectively what it's like for older people to live with having a diagnosis of cancer alongside pre-existing co-occurring long-term conditions. So just I guess as a little bit of a background, as Yolanda mentioned, the study was funded by the NIHR ARC, the Applied Research Collaboration based in Wessex, and it began, I guess, in around 2018 and has been ongoing and has led to other work off the back of it. It was part of a wider study that I will touch on very briefly at the end, that also include perspectives of the healthcare professionals that work with these older adults. And I'm happy to discuss that later as well if people have questions about that. But for this presentation today, I very much wanted to focus on the experience of the service users. So I'm just going to talk through a little bit about why this area is of interest, and then go into a bit of detail about the methods that we used before discussing the findings in more detail. So I guess to begin, and I use this picture, I thought it'd be nice and seasonal. I guess the crux of all of this is that when people are older, and a lot of the time it's due to advances in technology and diagnosis and medication and so on, that people are likely to have accumulated a number of conditions. And also older people are more likely to be diagnosed with cancer. Independent of age, people with cancer are also more likely to have co-occurring conditions. So this is not an uncommon experience, and it is something that we need to consider because it can have a huge impact on how people manage their cancer, but also how they manage the other conditions that they have at the same time. And this is increasingly pertinent given that there's a move towards supported self-management in the community, where older people or anyone with a condition is expected to do a lot more of the self-management by themselves, kind of outside of the hospital, and expected to link in but with the other organizations around them a bit more as well. So I guess just to add to the picture a little bit more and just talk about, you know, how does being older potentially impact the experience of having cancer, just specifically, I guess. So having multiple conditions alongside cancer in old age increases the likelihood of delayed diagnosis, lower functional status, treatment complications. It also means less favourable prognosis because of all of those things, and ultimately just a lower quality of life across the board. And this is perhaps linked to things like masking of symptoms. It might be linked to presentation of symptoms, that it's just it's later. It might be to do with the nature of the co-occurring condition as well. So it might be linked to maybe the fact that somebody might have a cognitive impairment and mightn't be able to express symptoms or express pain, for example. So when people receive a diagnosis later, it can obviously mean that the cancer has progressed a bit more by the time that it's diagnosed as well. The other, I guess, key thing here is that the experience varies quite a lot. And while I'm talking about older adults, I want to really highlight that it's a very, you know, idiosyncratic experience where there's a lot of variation. The type of cancer that somebody has can have a huge impact on how it impacts somebody's life, and the long-term effects and the treatment that they get as a result of it, but also the conditions that they have alongside it. And generally what the research reports is that conditions that are more limiting, or the conditions that increase burden, are the ones that are associated with lower quality of life. And I guess that kind of makes sense, that the ones that take the most work, the ones that stop people doing what they want to do in their daily life, are the conditions that take priority for a lot of these individuals. And I guess a lot of what I will talk about today is about that process of prioritization that older people engage in. And when you have to self-manage lots of conditions, that some things take precedent and other things perhaps are not deemed as important, probably because they're not seen as being as interruptive a lot of the time. Another key thing to consider here is that older adults tend to be more frail. They might be or have frailty, and they might be more susceptible to side effects of some of the cancer related treatments. They mightn't have as much ability to cope with the toxicity of some of the treatments that can be quite harsh. And because of things like cognitive impairment or risks of delirium, there might be a reduced understanding of treatment instructions, or, as I say, delayed reporting of poor health outcomes. So treatment might be given perhaps inappropriately because people aren't the people with cancer aren't necessarily always able to express when it is not working well for them. So it's quite complicated and has to be dealt with quite carefully. And I guess this picture is complicated more so when there are multiple co-occurring conditions. And also we have to think about the sociocultural experience of older people in general. We know that aging is often associated with maybe financial difficulty or poverty for certain groups of people, and increased social isolation as people age. And this can cause difficulties in things like mobilizing the resources or accessing care, which complicates follow-up care, because if people have multiple appointments for multiple conditions, it's really important that they are able to and are supported to access those appointments, to be able to access the medications that they need, to be able to attend checkups and so on. So we really need to think about what is happening for older people in general beyond the hospital when they go back home, and what happens to them there as well. We also know that sometimes, because of cancer and its treatment, some conditions are also likely to develop after, which can add another complication to the picture, where people are perhaps coming to terms with the addition of cancer onto other conditions that they might have had before, but now they may also have developed, would say, increased levels of frailty. They might have heart conditions, or it might be linked to diabetes, for example, in some people as well. And all of these things compound to really, as I say, just complicate this picture. And in terms of the health system, this can lead to complications, which has, increased hospital admission, increased length of stay, and readmission. So it's a very complicated picture, is what I'm trying to get across, I guess. Also, as you can imagine, when somebody is receiving treatment for cancer, they're already at a heightened risk of polypharmacy. But when you add in other medications into the mix, there's this extra layer of complexity again, where you have perhaps medications that might interact, you have conditions that might interact with each other. One might exacerbate symptoms of another, and so on. So it's really potentially dangerous. And again, polypharmacy can also add to things like hospital admission, length of stay, and readmission into the hospital, which again, at a system level, has all sorts of implications. And I guess one of, the most surprising things for me coming into this body of research at the beginning was that we don't really manage or support these people very well, because a lot of the way the healthcare system is set up is very much focused on single disease focuses, and teams can often work in, really specialist teams can work in silos where there isn't a great amount of communication. And this is, made more difficult by challenges in, IT communication across teams and things like that. But further to that is the fact that a lot of the evidence-based treatments for people with cancer are often based on clinical trials, where older people or complex cases have often been excluded from the trials. So when a healthcare professional is trying to establish the correct dose, for example, or the appropriate treatment for people, they aren't always able to draw on a strong evidence base, because traditionally those people have been excluded from the research, which is, I guess, a challenge for those healthcare professionals then, and how best to approach supporting these individuals. And again, adds to the likelihood that things might not work well for the individual who is receiving that treatment, and that it might not always, their needs might not always match what the protocol of standard treatment would suggest. So when we began this research, there was very little known about how people experience this, and I guess what we wanted to find out is, what's it like effectively, what is it like to be managing lots of complex conditions alongside trying to manage the diagnosis of cancer. So that is what I'm going to focus on today. And as I said, this work formed part of a larger project that looked at personalised care. So if you're not familiar with personalised care, it seeks to move away from this single disease focus and have a more holistic approach that tries to, I guess, ascertain and build treatment around what the values and the priorities of the person receiving care are, and to ensure that when we say that, supported self-management, that they would truly be supported for all of their conditions, not in siloed, fragmented systems where they have to try to tie up all the pieces themselves. So the aim of this research was to identify how older people with long-term chronic conditions manage their health. So how do they manage day to day, and how do they meet their health-related goals? So what is it that they want to achieve? What is it that they want to what point do they want to get to after they have completed treatment for cancer. So as I mentioned, there are two studies here that I'm going to talk about today. There's a qualitative synthesis of the literature, and this was focused on the experience of older adults again, and then we did some interviews as well. So both of these papers have been published. So I'm not going to go into a huge amount of detail on the methods, and I'm going to discuss the findings together rather than talk about them separately. So I suggest if anyone really wants to find out about one of these methods in more detail, or the findings of one of these studies in more detail, that you go to the papers. When I was putting the slides together for this, I felt it might be a bit dry to talk about them as two separate studies when a lot of the findings actually complement each other and were linked to each other. So in terms, I guess, just to give an overview of the methods, with the review, we searched 6 databases for primary qualitative research, so research that had been done with older adults who had the experience of living with cancer and multi-morbidity. We based the search terms and the process of analysing the data on this cumulative complexity model developed by Shippey et al. And I'm not sure how clear this is, but I'm happy to share the slides with anyone who wants them afterwards as well. And this theory is quite useful in that it looks at the workload of the individual. So in terms of what has that person going on in terms of the everyday tasks that they must do. So it might be self-care, it might be looking after their family, but also the health related workload of it. So attending appointments, paperwork, all those kind of things. And it also looks at their capacity, so their ability to engage in these activities, with the, considering everything from psychological, cognitive capacity, education levels, social support, and then resources like financial resources as well. And the theory kind of, as you can see here in the image, outlines that these factors can have a huge impact on whether people are able to access and engage with healthcare services to lead to better outcomes. But these are made more difficult by burdens related to treatment and burdens related to the illness. So conditions might make it more difficult to undertake the tasks, for example. So if you're not feeling very well, obviously it's very hard to do a lot of the work that's involved. And I find it quite useful to conceptualize what people do in terms of work, because it does seem to be that there's an awful lot of different tasks involved beyond their everyday responsibilities. So there is a lot of work in patienthood, and I think it's really important to point that out. So as I say, feel free to read a bit more about that model. In the review, we focused on workload, we focused on capacity. We looked at the balance or the imbalance between those two things. So where workload may be tipped over on one side and led to reduced capacity, what impact did that have? What when somebody had a high level of capacity, that seemed to make it easier to manage the workload, and so on. So to look at that balancing between the two, and then what happened when it didn't work, when there was an imbalance. And again, to frame it like that was quite helpful, because this model suggests that might lead to things like low quality of life and problems with engagement and so on. So that was kind of the theoretical framework that underpinned the review that we did. And I guess just to give a sense then as well with the qualitative study, so we looked at a broad range of studies, and we identified 30 papers reporting 28 individual studies. And I think with our inclusion criteria, we're looking at any study where we could extract data that related to the experience of older adults. We only found 6 studies that explicitly had it in their aims that they were looking at that. But we found some other studies that focused on maybe the experience of people who had cancer, but within that group were older adults who had multiple conditions. Or we had other studies that focused specifically on the experience of multi-morbidity. but didn't have a specific focus on cancer, but we were able to extract data relating to that. The challenge with that is that because it wasn't an explicit focus of the study, it was difficult for us to extract a lot of data from some of those papers. Obviously, when you're doing a secondary analysis, you can only work with the data that's presented in the final published piece. So if there wasn't a lot there, it was tricky to analyze. So I guess we wanted to make sure that we could build on the review then, which is what led to our qualitative study, because identifying data that related to the precise topic was really sometimes hidden in these other articles. And also a lot of the individuals that were included were of a high socioeconomic status or perhaps a high education level. Most of the participants tended to have had a diagnosis of breast cancer, and most were female, overwhelmingly so, in fact. So when we initially carried out this review, we knew that we would need to do more research to tap into, I guess, a broader experience of individuals as well. And that's what led to the qualitative studies. So as I say, I'm talking about these two studies in kind of parallel, just to get a sense of what different methods we used, but I'll talk about the findings together as well then later. So we did one-to-one interviews. We recruited 8 older people and 2 caregivers, and we used 70 as the cutoff as the age, and there's a lot of debate about what counts as an older person, and indeed in the review we had found some studies identifying people from age maybe 65 plus. There's and we selected 70 as our cutoff for the qualitative study. So they were individuals who had completed treatment for cancer. Again, we're focusing a lot on self-management with what I'm talking about, and so it was often after treatment when people went back home and perhaps were out of that care that they were receiving in the hospital, and it was required that they had at least one other health condition. So just to get a sense of the range of people that we included, we were recruiting largely from a team that we work with in the hospital who worked with colorectal patients. So it was a focus more so on that group. We had one participant with endometrial cancer as well. But we managed to get some male participants, which was quite good. But again, there seemed to be more uptake from female participants. But we got a wide range of other conditions that people had. And as well, touching on what I said earlier, I guess the level of interruption that these different conditions would give as well is quite varied. So we felt that this would be enough that to help us build on what we had found in the systematic review and synthesis of the other studies. And you can see there's quite a difference in the age range as well. And I will also point out that this group, there was a lot of differences in terms of the education of individuals, which is something I'll touch on later, and also the financial resources available to these people. So even within this sample, there was a lot of variation. And if anyone is not familiar with qualitative methods, often we work with quite small samples and do really in-depth interviews. So each of these interviews would have been about 90 minutes to 2 hours. So we got an awful lot of data, and they were very rich data set to be able to talk about the experiences that people had as well. So with this analysis, we did a framework analysis, and we found that a range of factors influenced the workload and capacity. So again, touching on that model that I described as well from Shippey, that we were focusing on that when we were doing the analysis here for the qualitative as well. So as I mentioned, I'm going to talk about the findings together. And the reason I've decided to do that is because, as I say, the papers themselves have been published. And I think it will make for a more interesting discussion of the findings rather than going through, here's what I found in the review, here's what I found in the qualitative, and then bringing them together. I thought it would be easier to just bring them together from the start and hopefully get you thinking about the types of things that came up. Some of these findings were only found in the qualitative research and hadn't come up in the review, and vice versa. But I think what my goal is today is just to present what it's like, rather than kind of really focusing on where it came from. So what we found is, I guess in terms of the theory, is that having multiple conditions really complicates people's ability to manage their conditions. It poses a threat to health and well-being, and it adds burden, it adds work, it makes things more difficult for people, but also simultaneously reduces their ability to do the things that they perhaps need to do. So it diminishes their capacity. So it makes it very complex for people. And I guess what I'm going to talk about now is these 5 overarching themes that came up across both the synthesis and the qualitative study. So I'm going to talk a little bit about people's reaction to cancer and the consequences of their cancer and the treatment, and how this influenced their pre-existing conditions, how it influenced their experience of aging, and what their views were on how cancer impacted the picture that they were living with. I'm also going to talk a little bit about this strong sense of personal agency, that we found that people really had this strong motivation and perceived responsibility to look after their health and to self-manage, and that had an impact on how they approached their health in general, and also how that impacted their view of the work and their view of their capacity to manage that work as well. I'll also talk about the resources, so internal and external resources that influenced their ability to manage their health. And the last 2 themes here kind of relate more to their interactions with the healthcare system. So in particular, their interaction with healthcare professionals and the influence that this had on how they viewed self-management and what they should and shouldn't be doing, but also then the wider healthcare system, which we found that it often adds work, adds difficulties and challenges, and pushes work back on the older adult, rather than necessarily supporting them to self-manage as you would hope would be the aim. So starting with the first theme, one of the things that we found, and I guess this is a positive, so I was very keen, particularly in the interviews, to look at potential positives to having multiple conditions alongside cancer. And although they were few and far between, one of the things that came up was that people reported that actually having had multiple diagnoses before, this was just seen as another thing to add to the list. So it wasn't particularly upsetting or groundbreaking. And this is a sentiment that it has been found in the literature as well, where, you know, if somebody is younger and they receive a diagnosis of cancer, it might be their first time getting a serious diagnosis of a condition, and that can be quite difficult for them to manage. But also people who have multiple conditions have developed an understanding of how the healthcare system works, how to navigate the system. They know the people to call maybe, or they might have a good relationship developed with their GP, for example. So they were quite stoic in their response sometimes to having had cancer. And it really, for a lot of people, it wasn't the most important thing, particularly if they had other health and social problems. So if they had another condition that was seen to be more interruptive, people spoke an awful lot about arthritis, for example, because it led to functional limitations. And when they went home and had completed treatment for cancer, it was the arthritis that became the priority again for them, because that was what limited their day-to-day activities. So again, quite interesting coming from where I come from, a cancer research background, to see that it wasn't necessarily the most important thing to these people when they went back home, and that it wasn't always prioritized in terms of the self-management activities that they needed to do, either, because it wasn't something that was interrupting their life very often. However, what people did say was that there was often uncertainty about what was causing symptoms that they experienced. And this is particularly in relation to, I guess, vague symptoms that may be pain or fatigue, for example, where it wasn't necessarily clear where the symptoms were coming from. They didn't know if it was due to cancer. They didn't know if it was due to a coexisting condition. Their age, was it just getting older? Was it just, recovering from the stress of what they'd been through? Or if it was this interaction. And the other challenge with that is that they often didn't know who to report it to, because if they didn't know where the symptom was coming from, they didn't know whether it was appropriate to mention it to their cancer nurse specialist, for example, or maybe if they should have been mentioning it to a diabetes specialist or the person that they were working with for their arthritis or another condition. And this led to a little bit of fear around recurrence, that they wouldn't necessarily know when to report to the cancer specialists, and that something might not be picked up as a result. So there was a fear there that there could have been something there that wasn't being picked up because it was vague. And another issue that came up for people related to how, if they had multiple conditions and they had developed, I guess, a sense of balance or equilibrium, or had figured out a way to work through having multiple conditions, that suddenly the addition of another condition made it difficult because it changed the routine and made it very difficult for them to assimilate it into their life, and might have disrupted the other conditions that they had. And this made it really difficult for them to maintain an identity beyond being a patient. The more conditions people had, the more work that people had, the more burden they had, and perhaps the reduced capacity that they had as well. So it seemed to be a job that they were doing, maybe, and this job was made harder when a new task or a new series of tasks was added into the picture. What people did say was that when they had a diagnosis of cancer, sometimes they could cede control of their health completely to the professionals, and they said that this was unique to cancer and their experience of cancer treatment, that they didn't have to do all the work by themselves, that it was taken over by the specialists. They were supported, and they didn't have to actively manage their health. Their appointments for other conditions were dealt with, and they were really supported with their other conditions. But this was really difficult for them then, once cancer treatment was ended. They had to go back to managing all the other conditions, and perhaps go back to managing all the other conditions and not being themselves, or not being the same person that they were before treatment. So having, to go back to that was quite difficult, especially when there was long-lasting side effects and ongoing problems. And one of the things that came up with our sample, which again was different to anything that we had seen in the synthesis, again probably due to the nature of the sample there, was that it was very difficult for people who had a stoma, because they were trying to manage the stoma alongside their other conditions. So one woman, for example, spoke about how fiddly it was to manage when she had arthritis in her hands, and how difficult it was for her to try and to manage the stoma. And other people spoke about dietary needs, and trying to figure out what they could and couldn't eat, or what worked well, but also trying to make sure that they were balancing the nutritional requirements perhaps for other conditions and things like that. So having to adjust at home afterwards was quite difficult for people. So as I mentioned, there was this really strong motivation, this responsibility that they felt that, and it might be a generational thing as well. They were very proud of the NHS and very much wanted to support the NHS by staying well for as long as possible. But in spite of that, when they were interrupted, when they had a condition that stopped them being themselves as they saw it, that was quite difficult for them to cope with. People spoke a lot about not wanting to become immobile. They didn't want their life to be further disrupted by illness and functional disability. They didn't want to, a lot of them mentioned about ending up in a care home. They wanted to maintain their independence. So these were people living independently, maybe with their spouse, but they were living in the community. They weren't in care homes at this point. And they were concerned that if they had another condition or if their cancer came back, that they might end up becoming too unwell, and that they would eventually reach a stage where they would not be able to live the life that they wanted. These people wanted healthcare to be peripheral to their life. They didn't want it to be the central focus. But a lot of the time, especially when there was an increasing number of conditions, it really became a job every day, attending appointments, dealing with paperwork and documentation. And there was a lot of admin associated with managing all of these conditions, not to mention the physical impact of having lots of conditions. And it was difficult for them to balance viewing themselves as autonomous, people, with constantly being a patient, and constantly being in the healthcare system, and being a number, rather than being, a father or grandfather, or a member of the local church and things like that. The work seemed to take over a lot of that identity. And I guess touching on that as well, in terms of the resources, then to move on to the next theme, there was huge differences, even within a small sample of, in terms of people's ability to manage that administration, and that work. So, for example, we had some people who had worked as nurses, when they were younger, and they knew how to manage the healthcare system. They had filing systems. They had all their documents neatly organized. They knew how to advocate for themselves. They knew how to, as they described it, kind of little tricks to get through the system. Whereas conversely, we had people like, I think this quote really nicely illustrates it, that they had so much admin, they didn't know how to organize it. They didn't know enough to know what was important. So they just kept it all, and it just made it really difficult for them to figure out what they needed to do, and what was I guess concerning for them then was how much more difficult this would get if there was any future memory loss, and how this would impact their care. So that fear of cognitive decline in a lot of these people, again related to that idea of maintaining independence, they were afraid that with all the work they had to do, that those internal resources were really important, and that if they lost that capacity, that it would be really, really difficult for them to manage multiple conditions, and in particular the work associated with the multiple conditions that they had. And I link to that again, if we talk about the external resources, the financial capacity was seen as a real key facilitator of that independence. So people spoke about things like being able to get a taxi to an appointment, and that this was so much easier because they mightn't have been able to walk to the bus stop. And if they could walk to the bus stop, sometimes the bus would pull up too far away from the footpath and they couldn't then get onto the bus, so the bus might be crowded. Whereas having the money to be able to afford a taxi and made things easier for them. And they also talked about things like being able to afford a cleaner or domiciliary care support, as well. And those things helped them to maintain independence. And linked to the second point on this slide, help them not to have to rely so much on other people, which a lot of the time they didn't want to do. They didn't always want to ask for help, because I guess there was a fear if they started asking for help that they would need so much help, and that they didn't want to burden their neighbours, their family and their friends. But other people that we spoke to lacked a supportive network, even if they wanted to ask for help. Some people describe difficult relationships, broken down marriages, isolation and loneliness. A lot of these people were at an age where their friends and their neighbours were also falling ill and dying. So their network had reduced significantly, and it was really difficult for them to get help if they wanted it. And I guess on the flip side, again, trying to find the positive, some people did say that actually having the diagnosis of cancer had led to an opening up of a network for them, that they had been kind of plodding along with their other conditions. And when they linked in with the cancer services, and there was local organizations and charities and support networks available to them, that they had actually met other people who lived nearby. Some had joined choirs and volunteered at the charities and things like that, and that actually helped them. And this, when I say the positives, it's not to minimize the experience, but I guess it is just to show that there are perhaps some good elements of particularly cancer care that can be applied to how we help people with multiple conditions moving forward as well, and just things to be conscious of. And the other key players, I guess, in the picture for a lot of these people were the healthcare professionals that they worked with. So a lot of the people that I spoke to, and as well the people who had taken part in the studies that were in the review, talked about how healthcare professionals are really influential in this picture. So while Shippey's model very much focuses on an individual level, and how the individual experiences burden and capacity, there was this view that actually the healthcare professional could protect the person perhaps from some of that workload, and support the person better to achieve the appropriate levels of capacity. And people spoke about some of these things, about having the rapport, having well-timed information from somebody that they felt that they could ask questions to was really important. And that if they had concerns and they weren't quite sure that it was definitely this particular person that they should be asking about it, that was able to happen. They said that sometimes they felt that it was a waste of time asking questions because there was this sense of busyness portrayed from some of the healthcare professionals, that there was no time, and that if they asked something that, it wasn't something that healthcare profession could deal with. So that's why it was so important for them to have somebody who they saw as approachable, because they were so conscious of those demands. And some really felt that their concerns were often dismissed or minimized, or, downplayed as, oh, it's just aging, or, some people spoke about how the healthcare professional said to them, you're lucky to have gotten through cancer, what do you expect? Which they felt that was quite dismissive. And people spoke about how they felt that there was stereotypes, particularly in relation to aging, that there's this assumption that there's a level of comorbidity and ill health that comes with aging, and therefore people should put up with it, and perhaps we're not always as supportive as they might have been to a younger person, and that was felt by the individuals. So when they felt that their concerns were dismissed, some of them attributed that to what they perceived as perhaps an ageist response from the healthcare professionals as well. And that had an impact, because sometimes people were making decisions about their health to live their life in the way that they wanted to, and didn't always communicate their decision-making process with the healthcare professionals, who they felt didn't want to hear from them, I guess, to put it bluntly. So where they had contradictory, overlapping, clashing treatment regimes, or contradictory self-management strategies, they would engage in what we call strategic non-compliance, where they would modify what they had been told to do or ignore guidance so they could live their life the way they wanted. So, for example, this quote highlights that a woman, she took diuretics for her heart, and it was really difficult because she had arthritis and mobility issues, which made it really difficult for her to get to the bathroom on time. But she really prioritized her social life. It was really important for her to remain part of her social networks and to meet up with her friends for lunch or go out with local groups on days out and things. So she would sometimes not take the pills as prescribed, sometimes wouldn't take them at all on particular days, but hadn't told her healthcare professional about this because it had never come up in conversation, because they would ask maybe, are you taking the medications? And she would say yes, but the day-to-day taking of them wasn't consistent. And it might have been that the healthcare professional would have been able to support her in doing this safely, might have been able to offer another medication, or might have been able to perhaps explain the importance of why medications needed to be taken as prescribed and so on. So I think it's really important to note, and this is a key aspect of it, is that people, when they had so much work and they had limited capacity, they had to prioritize the things that they wanted to do. And prioritizing, for example, for this woman, her social interactions was deemed more important than the medications in her case. And again, I guess beyond the individual healthcare professionals looking at it at a system level, it was very difficult for people to manage all the different systems. They felt that they wanted healthcare systems to make things easier for them, but they did not support with the day-to-day health work that people had, and if anything, they added to it. And this was largely because of different systems working in silos, systems not talking to each other, not working collaboratively, not delivering efficient integrated care. And they talked about all of the work associated with organizing multiple appointments with different people in different locations for follow-ups, blood tests, scans, and the paperwork is one side of that, but even just getting to those appointments, if you think about individuals who have maybe frailty and mobility issues, who don't have somebody to give them a lift during the day, who can't afford taxis, who can't maybe get on public transport, and it makes it very difficult for people. They spoke about maybe wanting appointments all on the same day at the hospital, for example, whereas that didn't always happen. They might have had a meeting with a heart specialist on a Monday and be back on the Wednesday for a meeting with a cancer nurse, and so on. And one of the other things they talked about it was how, as this quote illustrates, that they're, again, this belief, what would older people be doing, that they're at home all the time, and that social element again was really emphasized, that when they were told that somebody might be coming around to see them, they would be told that they're going to come on Thursday, and they wouldn't have necessarily been given a time. Now, they understood why that happened, that the people didn't always know when they would be able to get there, but even if they had said the morning or the afternoon. And this person talks about they couldn't even go to the garden in case they didn't hear the door, because of their functional limitations, and they wouldn't get to the door on time. So they felt that they were waiting in all day, watching the door, and that actually this was really not helping people to live a happy, fulfilled life, and was quite restricting, because it was hard enough having all these conditions without the healthcare system also adding to the work, to the isolation, and to the challenges that they were faced in managing the conditions. So it really, as I say, it is a very complicated picture, and it makes it quite difficult for people to manage. And I came away from a lot of the interviews a little bit shocked at how much they had to do. There was so much multitasking, so much coordination, and on top of that, feeling so unwell and being functionally limited as well. It's very difficult for people to manage. So I guess just to discuss that a little bit, and I can see some comments coming in the chat as well, so I'll have a look at those in a second. But just to kind of get a sense of where we're going with this, and to summarize the findings, we found that the experiences can be really complicated by the coexisting health and social care needs. that they really value the maintenance of their quality of life, and they want to be able to do the things that they want to do. They want to engage in valued activities the same way as anyone would. But that there's this very complex interaction of capacity, treatment burden, the services, the resources available to them, that are all interacting and working against each other a lot of the time, to disable the person or to pose barriers to the person living their life the way they would like to. The most pressing impact was often on things that perhaps healthcare systems and healthcare professionals don't always think about. I think we have a very strong focus on health outcomes, but we often don't necessarily think about how important it is for people to maintain independence, to maintain a social life and leisure activities. And I guess that idea of living a fulfilled life is really important. So we need to really think about these models of self-management, and how they fit with the life of the individual, and to think about things like social support, the financial resources, and how much actually whatever self-management intervention is in place might actually impact the social life that people have, and also the financial resources. Because again, people spoke about things like the cost of car parking at the hospital, and if you've got multiple conditions, you're there more often. It's if you don't have a lot of money, which we know perhaps older people often don't have if they're on their pensions and so on, it makes it far more complicated, and really makes it very difficult for them to balance all of these things in an ever-changing picture. So we know that these disjointed structures within the healthcare system makes it very difficult. And again, a lot of the way that the healthcare system is set up has traditionally been based around single diseases and single disease pathways. But what works for a single disease is not necessarily what works best for the person. We need to think about how these different conditions accumulate, interact with each other, and that having, while it is very good to have a supportive specialist nurse, perhaps we need to look at more multidisciplinary teams and how they're looking across conditions as well. So we need to move away from that single disease model for these people, and look at a more comprehensive approach, and really look at the cumulative impact of these conditions on activities and quality of life. We know that these are quite a diverse cohort now, and I'm always quite careful, as I said earlier, with the caveat that these people have quite different things going on. The issues are quite different and disparate, but we know that there's complexity. So we know that care should be personalized in a way that works for them. We need to figure out a way to develop a healthcare system that is as minimally disruptive to the person, but maximally supportive, and that needs to have an inherent flexibility to it to deal with the different needs that might present, and the dynamic needs as well, because we know with a lot of these conditions that they can flare up, they can kind of ebb and flow. They might not be the priority at the moment, but they might be in 6 months' time, so that it needs to be constant communication with the individual about what the priorities are as well. And I guess to follow up on this, I attended the Richmond group launched a 1 in 4 manifesto, and I'd really encourage anyone who's interested in multi-morbidity to have a look at that. And they presented it last week, and one of the slides was this one here, which again I'm not sure if you can see quite clearly enough, but they talked about the challenges with the current care model, and as I said, this only was launched last week, and it does reflect a lot of what we have found, that there is a need for this personalization. There's a need for a focus on well-being, mental health, care transitions, social connections, diet, nutrition, mobility, and physical activity. So a move towards perhaps just focusing on the health care and treatment, but also looking at that wider prevention model as well. One of the things that we developed as a result of this was a tool called the Chat and Plan. And the idea behind this, and I will share it in my next slide, was that we wanted to support healthcare professionals. And I'm not going to go into too much detail again on this, but I'm happy to talk through about it in the questions. We wanted to support healthcare professionals to have conversations with individuals that were more holistic. So this was again coming from these findings from the older adults, where they felt that people weren't looking at them holistically. They weren't really listening to what they had to say. They weren't basing things on their priorities, but also findings from the healthcare professionals themselves, who described how they didn't feel confident looking at other conditions. They didn't really feel comfortable setting goals. So this tool was designed as a way to support people to structure their conversations when they're talking to people with complex conditions. Where this was used in a trial in primary care with people with cancer, and we're currently developing training for its use as well, even in a domiciliary care setting. And the idea is that this might be a way to support, I guess, personalized care conversations with people. So, as I said, I don't want to go into too much detail on that because it's kind of deviating from the topic at hand. But just so you know, this is what the output of that work was. And this is kind of the direction of travel that we're going with, is to very much support the healthcare professionals to better identify and assess the support needs of individuals, and in turn personalize and individualize the support that they give them then, to enable them to better self-manage their conditions in the community. So just before I wrap up, I just want to highlight, something has happened strangely here with the numbers, but just want to highlight some of the team that were involved, and to just mention the funder again, the ARC Wessex, who supported this research. So I'm happy to take any questions, and this is my email if anybody wants to email me, and my Twitter or X handle as well.
Okay, thank you, Teresa. That's such an interesting presentation, really wide-opening in many sense, because as you mentioned, this is an area that haven't been sufficiently probably explored, at least on qualitative data, well, quantitative either, I suspect. Just a fair question. I mean, you chosen a qualitative. What about the quantitative? I mean, just for curiosity. I mean,
we didn't find an awful lot on quantitative. I guess because we were trying to find out really what it was like, the lived experience of it. It lent itself to a qualitative design. There is some data that suggests that people who have had a diagnosis of cancer report lower health-related quality of life, for example, than people who've never had a diagnosis of cancer. But then also people who have multiple conditions report reduced health-related quality of life as well, suggesting that there's probably, an effect where the two would accumulate. But yeah, no, there doesn't seem to be a lot of, not that I'm aware of anyway, of quantitative data in this area. And yeah, I think hearing the stories allowed for that kind of richness of the data to really get a sense of how this works or doesn't work for individuals as well.
Yeah, so thank you for that. I'm opening the floor for questions. I mean, I'm just, while I check if I miss something, but you can either, ideally, if you don't mind, I mean, it's great if you pop your mic on, if you raise your hand and pop your mic on and talk. Otherwise, we're happy for you to type your questions in the chat. Yes, please, John.
Yeah, hello there. Thanks for a nice talk there, Teresa. I'm a human nutritionist by trade, and I was wondering whether, I'm sure that surely you used for their cooking, the way the management of their cooking and nutrition as a confounding factor, because that must obviously, it would impact on their overall health and recovery from disease and just treatment.
Yeah, so it did come up a lot, as I say, especially with people coming like learning about how to adjust and live life with a stoma, for example, and what they could handle. But a lot of people with, you know, after chemotherapy, for example, as well, certain foods that they might have eaten that, you know, they mightn't, you know, have the appetite that they would have had, and then that has a huge impact in terms of nutrition and frailty and risk of falls, and the impact that that can have then on, you know, waist and muscle loss and things like that as well. And if these people had been, for example, in hospital for a long time, and perhaps, you know, so I remember one woman spoke about being in hospital and not liking any of the food, and she had ended up quite frail. So by the time she came out of hospital, she had fallen a few times, and her arthritis had gotten worse, and things like that, because of that kind of wastage that had happened. So I think the nutritional side of it as well is really important. And I had people talk about diabetes in that sphere as well, and kind of, you know, making sure that they were, you know, keeping their blood sugar levels and things like that, which was difficult to.
Yeah, I can imagine balance. That a lot of treatment for cancer does change your taste sensations as well.
Yeah, and your just your digestive system, you know, your response to it, like how it makes your stomach feel and things like that. And I think, you know, we know that people as they get older end up with a reduced appetite anyway. So I guess adding in cancer into that puts them at a really high risk of just not getting enough nutrition. And I guess, you know, on the flip side of that as well, we had people talking about, you know, some people were really good with technology and had been able to organize online shopping and make sure that they had the fridge full of foods that were appropriate for them and things, whereas other people, I mean, one of the people I interviewed, and I went to his house, and he just had tins of spam, that's what he was eating, and he said he didn't know how to cook. His wife had died, and that was kind of what he was eating. So, you know, that level of education, you know, that capacity, isn't it, to access those things as well, and the knowledge and financial resources to access some of those things as well. So I say there's a lot going on there, you know, there's lots of different angles to it.
Yeah, I'm sure there is, yeah. Thanks.
No problem. Thank you for the question.
So while we wait another question to come, I jump in again on a note of what you were just mentioning, the amount of different factors affecting or complicating this self-management. I was just wondering, obviously, you just mentioned chemotherapy and some of the side effects, and one of those side effects is also the sensitivity loss. So I suppose for self-management also affect the neuropathology, sensitivity in terms of the hands, the touch. So that's quite common after the toxicity of chemo. And I wonder the type of patients that you're looking at with cancer. Did you find they were usually, say, stage 1, 3 cancer, or did you find anyone in stage 4, for example, or that? Yeah, that's the question. I mean, it's someone that is going to be a cancer survivor, but a survivor presumably not in terminal stage of their condition. Is that right?
Yeah. So I can't remember off the top of my head would be the quick answer. But I don't think so. I don't think we had anyone who was stage 4.
Okay.
Where that, you know, and I guess this is the other thing, as I noted, we only had 8 participants, and I think it's really important to note that we're talking about these people who have an awful lot of things on. We're talking about capacity, and it might be that you know, the more unwell somebody is, the less likely they were to take part as well. You know, so I would imagine that the issues that somebody who's stage 4 and has had more aggressive treatment is facing is probably quite difficult, and quite different. And I guess other things is that fact that they would be in the system for longer, in hospital for longer, and I think that has a huge impact on them if they ever get back home again as well. And I think that's why a lot of them were so afraid of a recurrence. They were really concerned that if they got cancer again, that would be the kind of that would, being in hospital again for a long time would mean that they wouldn't get back home again, and they were really worried about that. So I know that's kind of a slight deviation from your question, but I think those people with stage 4 are likely to find things difficult in a very different way, I think.
Yeah. Apart from the chemo brain, I forgot to mention as well depression. I mean, so other, well, for cancer itself, I mean, it could be quite lead to depression or something.
Yeah, exactly. And we know that, like, you know, chemo brain depression affects your ability to concentrate. And I think that was the thing that struck me with a lot of this, is the amount of admin that people have to do, the paperwork that they had to. It was almost like they had to be project managers and coordinate their care. And obviously, if you are, you know, if you have depression, you mightn't be motivated to do that, but also you mightn't be, you know, you might have that clarity of thought where you're able to organize those things, and you've other concerns. And also, as you say, the chemo brain, it sounded like a lot of work to me, and you know, as an academic on multiple projects, I do a lot of kind of context switching and things all the time anyway, and I just couldn't imagine doing all of that work while not feeling well yourself. So
I was surprised. Sorry, surprised for that notion of agency that you started with at the beginning.
Yeah. So I think a lot of people felt really strongly that they wanted to maintain autonomy. It was just difficult for them to do so. Yeah,
thank you.
Yeah, no problem. Yeah, it was that, and I think that's probably central to a lot of what I'm talking about, is that when we talk about supported self-management, we want to support people who are able to live independently to do so. But when people have lots of conditions, they might need more support there, I think. And these people are willing, they are, you know, largely able as well. And I guess it's quite a particular group in that sense. But the system makes it very difficult for them to do it, and the nature of having multiple conditions, and as I say, the work compounded with the capacity issues makes it very challenging for them to do that. And that's probably true of any, you know, that's not cancer specific, I would imagine, although the cancer adds another layer.
I think that also it strikes me that probably pharmacy is the only perhaps more known intervention with medications review, and to review precisely polypharmacy, this deprescribing for people with multiple morbidities in general. But as you say, I mean, there's a need to develop perhaps more interventions tackling this from other angles. And I wondered your intervention that comes out of this study that you presented, the slide, one of the last slides. Is it addressing whom? I mean, that did you have in mind? I don't know, a GP or maybe I'd missed that.
Yeah.
But
so one of the things that we did with that was we co-designed that with a group of people. Some of them worked in primary care, some of them worked in secondary care as cancer nurse specialists or allied health professionals. And one of the questions we asked was, where would this sit best? And generally people thought that it would be something that would sit best in the community, and that that generalist approach to care in the community would be preferred, that secondary care is about the treating of the condition and you know, primarily, although they do, you know, obviously they do touch on some of the other things, but that when you're talking about managing multi-morbidity, that it lends itself neatly to general practices and yeah, community practices. So they felt it would be that, but not necessarily a GP. So it was there was a lot of debate about who should do it, but equally then, you know, we spoke to frailty practitioners and things like that, and there was a lot of people generally of the view that those personalized care skills are something that every healthcare professional should be able to weave into their practice, that it isn't necessarily something that is only done by certain people, that it should be part of the practice, that people can tap into that generalist skill set, even if they're a specialist. And that was something that came up in the Richmond, I mentioned the Richmond report launched last week, and Professor Chris Whitty was at it, and that was one of the things that he highlighted, that sometimes we get so into specialisms that we forget to ask about the broader picture. But it's really important to do it, because we know that if we don't look at the whole picture, that people might stop taking their medications, they might not attend appointments, and conditions might interact, and that will all lead to further problems down the line. So you can actually see it almost as a preventative approach by identifying those issues earlier, that you can help people. So we didn't design it with any particular group in mind, and I don't think we reached a definitive answer on who would be best to do it, although there was a sense that community based for that particular tool. I think personalized care, generalist care, is something that the whole healthcare system is going to be challenged with, especially as we know we have an aging population, and we know people are developing more conditions younger, which means they're accumulating more conditions by the time they reach older age, and just the system that's overly specialized, overly fragmented, and siloed doesn't always help, I think, at the moment, and it will need to change quite radically. And I think that's what that report, if you can see my slide there, that's what that Richmond report is hinting at, that there is going to be a need for quite a radical shift in how care is approached moving forward.
Thank you. Yeah, absolutely. Thank you. I wondered if I'm very cozy, taking more time myself today. If anyone else have any question to ask or type. So, perhaps no. Okay. So I think it was a question about the video. Someone who wanted to share with the team. So I said that it's going to be next, I think at the least it take a week or so, because it's not me uploading it. I need to send it to an office first, research office first, and then they upload it to the website. They manage that, but it will be available. I can send you an email, Teresa, if you like, when that happens. Okay, so if there are perhaps not further questions, I would like to thank you again for this presentation. It's fantastic work, very innovative, I would say, in regards to this topic, which is, as you say, quite relevant nowadays and growing in terms of multi-morbidity and complexity for care. Okay, so thank you very much.
Thank you very much for having me. Teresa. And if anybody wants to give me feedback or ask me any questions, feel free to contact me by either modes there on the page.
Okay, so we have your Twitter and your email.
Yes, exactly. Yeah. Thank you very much.
Okay. Thank you. Thank you very much.
Thank you. Bye-bye.
Bye-bye.